Hi, I'm Dr. Omar Bey. Hold on just for a second. God, let me just get this computer together. And we are Physicians Health Network, and so glad to be here today with you. We're a group of Black physicians that is dogmatic about educating the population, especially people of African descent, about health. Also, our second goal, I should call it a goal, is to increase the number of physicians from African descent, especially male physicians, because I think at some point near in the future, it'll be a crisis where we would love to have more young people of African descent, especially males, in medicine. If you know someone and that student is looking towards medicine, please, you can email us if we can do anything to help and assist. We would love to assist those students. As you see, our doctors are signing on. The other thing is that our webinar is every second Saturday at 1 o'clock. And please tell others about it. If you would like to see any of our past webinars, you just go to OBHealthy, the website, scroll to, on any page, scroll to the bottom and hit our YouTube sign. And all of our past webinars will come up. You'll be able to view any of them, and various topics, I think is well worth going in and taking a peek at those. All right. Also, if you come into our YouTube channel, please subscribe, because that way we can continue to bring this webinar to you. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your personal and private doctor can truly take care of you from a medical standpoint. All right. Next thing I would like to say is I just want to thank OBHealthy for allowing us to bring this webinar to you every second Saturday. We look forward to answering your medical questions. So if you have a question, please type it in. We will do everything in our power to. I'd like to start off and allow the physicians to introduce themselves. Dr. Kendall Sprott, can you start off, please?
Yeah. My name is Kendall Sprott. I'm a board-certified pediatrician. I specialize in pediatric critical care and general pediatrics.
Thank you very much. Dr. Atherley, please. Dr. Atherley, can you hear me?
Good afternoon. Yes, I can.
Yeah,
Good
can you
afternoon,
introduce
everyone.
yourself?
My name is Trevor Atherley. I'm a board-certified internal medicine specialist and cardiovascular disease specialist. Can you hear me clearly?
Yes.
Yes, we can.
Good. Okay. I practice predominantly in Essex County. I am associated with Newark Methodist Israel Medical Center.
All right. Thank you. Thank you. Dr. Ali, all the way from California.
Hi, good morning from the left coast. My name is Dr. Mazhar Ali. I'm a gastroenterologist with Scripps Clinic, and I practice in San Diego, California.
Excellent, excellent. Dr. Kevin Clark, please.
Hi, good afternoon, everyone. Dr. Kevin Clark. I'm a surgical oncologist. I practice at Newark Methodist Israel.
All righty. And Dr. James Court.
Dr. James Court from East Orange, New Jersey. My place I practice is Newark Methodist Medical Center.
All right, thank you very much. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician and with a subspecialty in nutrition, and just so glad to be here and be able to be a part of this webinar. So let me explain, and I know we've been advertising that we're going to have an orthopedic surgeon who is a second generation, and we're so proud of Dr. Lee. Believe it, this morning about 7 o'clock, he calls me and states that he has 3 emergency orthopedic procedures to do. So we're going to change the topic a little bit. Hopefully Dr. Lee will be able to join us a little later. He stated that he's on his last case. Hopefully it won't be too long. and he'll be able to join us. But we're going to talk about colorectal carcinoma or cancer because it's colorectal month. And Dr. Kevin Clark, our surgical oncologist, is going to start us off, and we're going to talk about this because I think it's so important, especially in our communities, to stay up on a type of cancer that can be caught early. And we truly have surgical procedures and medical procedures that we can do to really help patients that have colorectal problems, and especially colorectal cancer. Dr. Kevin Clark, could you start us off, please?
Sure. So that's correct. March is Colorectal Cancer Awareness Month. And it's a very important cancer. It's the third leading cancer, both in men and women, and a significant cause of morbidity and mortality. What's interesting about colorectal cancer, it's one of the cancers that we can actually potentially cure and prevent. I'll let Dr. Lee talk to us more about the screening and prevention aspect of it. But it's a cancer that we have the opportunity, as opposed to some other cancers, of making a significant impact. And to some degree we have. Its incidence, which means the number of new patients that are getting colorectal cancer, has actually decreased over the last couple of years in the majority of patient populations, except for young Black males. It seems like young Black males, and we'll get into this a little bit more in detail, it's the one group where it seems to be increasing, and our screening criteria has changed from age 50 to now 45. And that's mostly in average risk, it's age 50, but if you're at increased risk, and again, we're going to define young Black males, 40 to 45, are going to be in that high risk or relatively high risk group. And that's the age that we should start screening patients. Mm-hmm. When we talk about screening in colon cancer, as in most cancers, we like to diagnose things before it becomes a problem. So when we talk about screen, it's before symptoms arise, and in situations where if a cancer is present, we catch it early. Colon cancer happens to have what we call precursor lesions. So before you actually get a cancer, you'll get polyps that can potentially be removed and prevent the development of cancer. So we like to do those things when we recognize patients who are at high risk. And again, anybody average risk over 50, high risk Black males and females, I'm not going to exclude females, age 45. If you have a family history of colon cancer, especially multiple family members, you should also get screened potentially earlier. And in patients who have inflammatory bowel disease or any conditions where there's a inflammatory component or inflammation within the large intestine, those patients should also get screened earlier. It's about 160,000 new cases per year, give or take, roughly. The distribution is, I think, relatively equal between males and females throughout. Once you get diagnosed, and I'll stop here just for a minute, because the treatment is going to vary with the diagnosis based on the stage and the extent. But I think we can go back to talking a little bit about what the screening entail, the different types of screening procedures, and how do we identify patients to be screened. So I'll turn it over to Dr. Ali.
Yeah.
Thanks, Dr. Clark.
Mhm.
So, as my colleague mentioned here, colon cancer is the third most common cancer. It's after lung and breast, but unfortunately, it's the second leading cancer of mortality, cause of death. But unfortunately, or fortunately, this is one of the cancers that Dr. Clark mentioned that we can prevent. And we can prevent it by colon cancer screening. It's one of the things that we can do, and one of the screening programs that we have in healthcare that is proven to be very effective, and it can also improve or prevent mortality. And one of the things, unfortunately, with colon cancer that we've seen for decades is that there's been a health disparity with colon cancer. It does affect Black men more, but we don't know quite why. But the other part of it that's a very important piece that I should mention is that amongst races, Blacks have a higher risk of mortality as well. And what we feel or what I feel is that's more of a health inequity more than anything else. The thing is that screening is the key. And about maybe 10, 15 years ago, the American College of Gastroenterology, which is our association, our national association, recommended for Blacks to start screening at the age of 45 when everyone else was 50. A lot of people didn't know that. But about a year ago, almost actually 2 years ago, there's new updated guidelines for men and women starting colon cancer screening at the age of 45 for everybody. So 45 actually existed in the Black community from even before those new recommendations. But now it's 45 for men and women. And there are a few different ways that we can screen for colon cancer. Mm-hmm. So the one that we kind of dread the most, and even me myself, is a colonoscopy. It's the one that you have to drink all that stuff beforehand to cleanse out your colon. You would come in for a procedure. The doctor would give you some medicines to help you to fall asleep. And then they take a camera, with a flexible camera, and they insert it from the bottom, and they navigate through your whole colon, examining and looking for what Dr. Clark mentioned were the precursor lesions. So we also look for cancer. We screen for cancer, but we look for these little precursor lesions, or they're called polyps. And polyps can be found in, I'll be honest, when I do these procedures, I find polyps probably in about 50 to 60% of people with no risk at all. Probably even more than that. But, these polyps are these little growths, and they're little babies that they're not creating a problem for anybody, but over time, over years, they slowly grow and grow and grow, and then they grow into something dangerous because these are mutations. But the beauty of a colonoscopy is when we go in and see these polyps, we can remove them, thereby preventing the problem altogether. So that is that is what we call the gold standard way, or the best way we could screen for colon cancer. But unfortunately, we're not even screening 25% of our population. We are not doing a great job with screening. And part of the reason is because screening is invasive. It's not like a mammogram. It's not like other tests. It's one that people, again, dread doing. And I totally get it. So another option that's available is something called stool testing, where we could submit a stool for DNA. And that is another way that we could check for colon cancer. Now, that screening test is not screening for polyps. It's screening for, and not the polyps are those precursor lesions. This is actually screening for cancer itself. And it's different than when we used to have traditionally what we call a hemoccult stool test. We still use those, but not very much anymore. Our technology is advanced where we have something called a stool DNA. And the names for those are called either a FIT test, a fecal immunochemical histological test, or a Cologuard test. Thanks. The Cologuard test, you probably see it on the commercials. And but those are the other ways that we could screen for colon cancer. And usually that colonoscopy that we would recommend, if we do a screening exam and there are no polyps found, we say every 10 years, you'll need another one, or some other screening modality. For a Cologuard test, it's usually, if it's negative, it's every 3 years.
Excellent, excellent. I have a question. As far as family history and what other things would a patient need to know about that would put them at higher risk?
Sure.
And what about weight and family history and things like that? How do you put someone in a high risk category?
So the family history does put somebody in a higher risk category for sure. But one thing to note is that not everybody who, or for people who don't have a family history, you're still at risk. We only find that family history exists in about 20%, 25%, but there's 75, 80% that do not have a family history of colon cancer. So just because it doesn't run in your family doesn't mean that you should not get screened. Now,
one of the things that we know with, and sorry to cut you off, Major, family history, what we're trying to identify is if there is a heritable mutation. And there are two specific ones with colon cancer that are fairly, not
Kevin,
common, but the ones that.
Can you define what a heritable mutation is in the audience?
So meaning that it's passed from generation to generation. It's not a sporadic cancer in the sense that it appears just in that particular patient, but in multiple subsequent family members, that gene or mutation can be passed from generation to generation. There are two genes or two conditions. One's called familial adenomatous polyposis, or FAP. And this is the condition where patients get many of those precursor lesions at a very young age. And we know that over time, if you have multiple polyps, especially these types of polyps, you will get cancer. So if we can identify these particular patients based on their family history, we can do procedures that are prophylactic to prevent colon cancer. The other one is called Lynch syndrome, or HNPCC, which is non-polyposis colon cancer.
Hereditary non-polyposis.
Hereditary non-polyposis colon cancer. And that's more common in the FAP patients. And Dr. Anderson knows these patients too, because in addition to colon cancer, they get uterine cancer. So in a family history, it's not just, is it a cousin? Is it an aunt? Is it a sister? We want to identify who in the family has it, when they had it, what type of cancer, and at what age, because these things may actually lead us to doing specific testing for one of these heritable mutations. Going back to screening, Mazer, I'm going to ask you, so if we know colonoscopy is the gold standard, but if somebody has a negative Cologuard or FIT test, how confident should they be going forward, and can you rely solely on those tests as good screening modalities?
So that's a good question. And when these tests initially came out, I was very suspect because I do feel that colonoscopy is a better option. But the reality is, when we look at the data is pretty good. The one thing, though, that I do tell patients when they do a test, if they decide to go with one of these stool tests, is that there is a 13 to 15% false positive rate, meaning that the test is positive. If it's positive, it doesn't mean that person may have cancer, but it could be just the limitation of the test that makes it become positive. But I could tell you the mental strife that people go through with it, and the stress that it can bring, makes doing a colonoscopy sometimes more worthwhile, just because of everything that can go into. The other part of it, though, that we just changed laws on within the last year, is that part of our healthcare law right now, screening colonoscopy is a health right benefit for everybody, right? And it's part of your health screening benefit. It's not going against that deductible. This is part of that screening exam. Now, what happened for years when the Cologuard was, or the FIT test was being used, was that through people's insurances, the insurance company would claim that as the colon cancer screening test. thereby negating the need for a colonoscopy. So if that test becomes positive, then insurance would not cover it under the screening benefit. Again, this law just got passed and came into effect in January, where we're now they're forced, they have to cover it but it was one of the reasons why I would tell people don't do the Cologuard, or maybe do, if you can, do a colonoscopy beforehand, just so you could avoid any extra cost that wouldn't be right anyways.
Can I make a comment?
Yes.
I think sometimes, we make good the enemy of perfect. And, I think the fear of a colonoscopy and the stigma of being examined that way in an uncontrolled way, when you have no control, you're asleep, that turns some folks off. So we look for something better that will harness or increase screening. But if Cologuard, and this is me asking the question, if Cologuard is positive when the cancer has already occurred, then technically it's not a screening test, right? It's just identifying a higher risk population that now needs to be screened and possibly diagnosed, right? So there's a difference. A really good screening test is one that's cheap, requires no major preparation, has a high specificity, meaning that if the disease is there, it'll pick it up at a high rate, and have a low, a higher sensitivity, and have a low specificity, meaning that when the disease is not there, it's negative, right? And I think the pap smears for cervical cancer is probably one of the best template for such a test. It's reproducible, it's cheap, no one requires any special preparation as in any of these gastrointestinal screening modalities. So my question then becomes, Cologuard is good, colonoscopy is perfect, we don't want to have them fight against each other. Is there a push to say to folks, listen, in spite of the rigors of the prep, in spite of the process of the prep, then colonoscopy probably is the best way to go?
So just, I'm going to follow up with this, when you talk about cancers, cancer cells develop from normal cells. And so the normal cells, something happens to them so that they change. And then they start to rapidly divide, and then to a point, if they divide enough, they'll form a tumor, and then at a certain point, they may get into the bloodstream and spread either locally through lymphatics or into the blood to other sites. So when Kevin talked about a DNA test, you're talking about something that's within a cell. And that's within a cell that either they're looking for it in the cell or breakdown from a cell. And so it may be that you might be able to pick up a cancer even before you're able to see a polyp or to see that there's an area that looks abnormal on a colonoscopy. And so I don't know, and again, I don't know if there's enough information. It may be that there might be an ability to have a pickup on a early cancer from Cologuard before there's a lesion that you could see with the colonoscopy. And so I just don't know if that's the case or not, or whether or not there's enough information, because I don't know, Cologuard hadn't been around for 50 years.
Right.
Colonoscopy's been around for a while. And so any thoughts on that, either Kevin or Mazer?
I think there's some limitations to all the tests, and I think so the DNA, the stool DNA test picks up tries to pick up those mutations. Those mutations are in adenomatous polyps, which are the polyps that lead to colon cancer, and also in colon cancer. So it'll pick up anything that's abnormal. The problem is it's not going to always, you can't, in certain cases, you can have a cancer if those mutations that it picks up are not there. So they're actually blind spots. And the same thing with colonoscopy. There are lesions that are flat that you can't necessarily see as a polyp, or or the classic polyp. So in both scenarios, you're gonna have areas where we're describing as blind spots. Even though the test is very good, it's designed to pick up certain things that we know. There are things that we don't know, certain mutations, or maybe a different pathway than what we're looking for that particular cancer.
So let me ask you this, Kevin. Suppose you have the Cologuard
Mhm.
and it's positive,
Yes.
okay? You then have a colonoscopy, you can't see a lesion.
Mhm.
Does that mean that you don't have cancer? Or is it too early for it to have become a polyp yet?
No, it means
So,
you probably have a false negative test, a false positive.
But I know that you can have a false positive, but could
Right.
it be a real positive?
right, so it may be that it's a very, very early lesion. And what you're picking up is just a molecular signature of it, but not the actual lesion itself.
So then what do? I know you can't remove something that you can't see, right?
Right. So you'll just do an interval colonoscopy. So you'll do a short interval colonoscopy at that point. Because if you can't see something, and again, there are certain limitations to colonoscopy. You could do narrowband colonoscopy. There's other more detailed types of colonoscopy, which Mesa can expand on to see, because there's also flat lesions that are areas that are problematic that you don't necessarily see very
So how
well.
often would you have a repeat Cologuard if
Yeah.
indeed you have had a positive, then had a colonoscopy, it was normal? Would you then repeat to see whether or not it remains positive?
So I would say that the risk of that is actually very low, though, right? I think that with our technology now, especially, we use high definition scopes, and anybody who goes under for a colonoscopy, and we know there's a positive Cologuard, if I go through that exam and I see that there's nothing there, I actually do it again. Right then and there, I go right back to the end and I just do one more double check. So we do what we can, and if there is if that patient doesn't have a high risk or they're not in that elevated risk category, we have a conversation about it. I'll say, technically, I think I have enough confidence here to say, doing your exam, that there's nothing there. This is a false positive. Let's bring you back in 10 years. If there's some sort, and again, it's a very individual discussion. If we're not comfortable with that, I may say, well, why don't you bring you back in 3 years or 5 years? But it's very individualized at that point. So
One of the comments you made earlier about colonoscopy being a right. There's some limitations to that. Because it's a right if you have insurance. If you don't have insurance, it may not be a right. And then depending upon what kind of insurance you have, your ability to get scheduled for a colonoscopy may vary. Because access to, before we started, we talked about the limitations in terms of, I'll say, the disappearance of Black GIs in our area. And so almost all of them would take Medicaid, some don't. And you're out in California, there's Medi-Cal. Someone that has Medi-Cal may not have the same ability to schedule a colonoscopy as someone that has better insurance. So there are some limitations to that. And again, we're talking about trying to have people get early diagnosis, especially with the gold standard, at this case, it's a colonoscopy. It may not be as easy to get colonoscopies for some folks than for others. And if you're Black and you have Medicaid, you may not be able to have timely colonoscopies done, or even the time to get an appointment to see a gastroenterologist may take a long time.
you're absolutely right.
Absolutely.
We're only screening. We try to screen everybody. We want to screen everybody. But the reality is we're screening 25% of our population. So, I do feel that these other tests, Cologuard tests, FIT testing, they add for more screening to occur. So we can screen a larger population of people. It's not necessarily that one may be better than the other. And, Dr. Anderson mentioned it too. A good screening test has a high sensitivity, and these tests do that. So I think at the end of the day, if we're just expanding who we're screening, and regardless of that modality, right? We just screen more, it's a win for everybody. But again, I think the one thing that our viewers should, I want our viewers to be aware of is there's options, right? And that gold standard, we do consider that gold standard a colonoscopy.
Right.
Just one last question.
Dr. Court's next.
Okay. Doctor, so I'm frustrated in terms of getting my patients seen for colonoscopies, especially in view of what was mentioned in terms of the insurance. They just don't take the insurance. What do I do? Where do I go? Dr. Mazur said, well, this is all right. Is there anything that can be done to help people get colonoscopies?
We're trying. Again, I think that, from the associations, my professional associations, American College of Gastroenterology, the AGA, there was a recent big win with coverage that was a gap for many years for since the inception of these Cologuard tests or these FIT testings. So I'm hoping that over time that gap will close. I don't think it ever will, because the reality is, and I think you said it, yeah, we'd love to get everybody in or have the ability to get a colonoscopy. I do feel it's a right. Everyone should have a right for it, right? Our systems don't allow for it. Our systems, there's walls around. I agree with you that we need to change that. I'm hoping with time and with some of these coverages, and as they get better, maybe that'll change. We are training more gastroenterologists, so there's a national shortage of GI doctors. That's one issue. The other issue
Or
is
of color?
yes, Black gastroenterologists. We have a critical shortage.
No, I'm just saying, you say you're training more. I say you're training more gastroenterologists of color?
Yes, we are. I'm part of a fellowship program here at Scripps. So, so we prioritize those sorts of things. It's important to prioritize those things at this day and age. But, the other part of this is that I lost my train of thought. Sorry.
I want to ask my question, over time, I'm in that elderly group, started to get the colonoscopies done, every 5 years. And now they're just pushing it, so that it's not, they're making the time that the insurance will pay for it after more years around. And you say, well, if you're not getting screened, then you can't get the diagnosis. The diagnosis may already be late if your insurance only pays for once every, what is it now? Every 7 years or
7 years, 10 years. Yeah. So I was saying, the other issue that we have is our population for screening has grown because the age changed from 50 to 45. So we've also now added millions more to that pool of patients that need a screening exam.
Now hold on, guys, because we got hands raised. So we got a hot topic going today, and I love it. Dr. Patrick Anderson, please, you, and then it's going to be Dr. Atherley. All right, we set the stage. Dr. Patrick, go ahead.
So, Mazur, again, two questions. One is screening versus diagnosis. So colonoscopy is meant to screen, right? However, it also has a diagnostic ability. So if you see something and you biopsy something, it's either pre-malignant or malignant. And then that's up to Kevin to figure out how he manages those. But besides age and known family history, the discussion tends to center around identifying polyps. Are there other risk groups that requires screening colonoscopy either at an earlier age or at more frequencies than the average population?
Yeah, so great question. And yes, there's the inflammatory bowel diseases. So patients who may have ulcerative colitis or Crohn's involving the colon. Typically, we recommend screening. Those patients go into a higher risk category after 10 years of disease. So for people who may have been diagnosed with something like ulcerative colitis in their 20s, we start screening in their 30s, 10 years later. So that's a population. Or if patients have symptoms that may warrant a colonoscopy sooner, for example, bleeding, blood in the stool. A lot of times somebody may see a little bit of blood in the stool and we think, well, it's probably a hemorrhoid, but other things that we think about, right? Maybe cancer, a polyp, an ulcer, or something else. So this would be, again, and depends on the situation for each person, but that would be also another reason why we may want to investigate sooner.
Excellent. Dr. Atherley.
I had a quick question about the anatomy of the polyp. Now, I presume then that we're talking about a structure, the polyp, which protrudes from the wall, from the inner wall, into the lumen so that you can see it when you pass your tube. Try and make it as simplistic as possible. Are there tumors which occur within the wall, which do not protrude into the lumen and thus may not be easily visible on colonoscopy?
So the polyp actually comes from the mucosal lining itself. And usually you can even see at the time of a colonoscopy that a polyp has a very different appearance. It could come out and protrude, or as Kevin mentioned, it could be a flat lesion. So it's something very flat, but it has a very irregular pattern within its tissue. So, but usually it's along that surface itself. It's not underneath that surface.
Yeah. So you called it the mucosa layer. That's the outside layer of the inner part of the wall of our bowel, right? So that it's not deep within the layers of the bowel. It's that outside layer the polyps develop. Oh, excellent, excellent. Kevin,
Yeah, but Omar, if I may make a comment, and Kevin can. So just bear in mind, this is one type of major type, probably more common type of colon cancer. So remember, the bowel wall has different component. We mentioned the word mucosa, which is the surface lining, but the bowel wall also has a muscular layer. And that's from an embryologic perspective, we call that the mesenchymal layer. Dr. Spratt, help me out here. It's been a while since you lectured me on this. Called the mesenchymal layer. And you can have cancers in the colon, not in, but of the colon that develops in the mesenchymal layers. And those kind of cancers can occur at any levels throughout the gastrointestinal tract, from the stomach all the way down. Some of those tumors, and help me out here, Kevin, sarcomas, for example, are some of those tumors. They're much rarer, but they can be problematic to diagnose. And oftentimes when patients present, they already present with obstructive symptoms.
Yeah, those are usually sarcomas or something called a gastrointestinal stromal tumor, but by and large, they're much, much less common than the regular adenocarcinoma, which comes from that mucosal layer. But going back to Dr. Atherley's point, it's actually, and this is one of the blind spots that we talk about, is the polyp typically normally looks abnormal, but there are polyps that don't look abnormal or don't have that as characteristic appearance. And those are the ones sometimes that they're flat. The mucosa itself may look a little bit injected or red, but it's easy to just go by it, not, if you're not really paying attention and miss those things. And again, not all polyps are the same. We talk about polyps, it's a growth. So polyp is a growth. And that growth, as Dr. Spratt had mentioned, when you talk about cancer, you start with a normal cell, then that cell acquires mutations and then grows. So polyps are growths, but they haven't gotten to the point where it's malignant in the sense that it can invade and spread. Now, there are different types of polyps, and we classify them based on how they look. So the growth pattern, if it's something called pedunculated, which means it sticks out into the mucosa, it sticks out from the mucosa rather, or if it's sessile, which it's flat, and it's it's almost next to or just parallel to the mucosa. And then there are different types of histologies. We won't get into those details there, but after we do a biopsy, the polyp, we look at it and we can tell to some degree the relative risk of either development of future cancers or in that particular polyp, if there's a chance of a cancer being in that polyp. But that gets a little bit beyond what we're talking about here. But again, it's one of the areas that there's certain times I've seen, just anecdotally, Mazer, you can comment, where a patient has a normal colonoscopy and it gets a 10-year bill to come back, and within 3 to 4 years, it's a cancer that's picked up.
Yeah, we call it an interval cancer.
Right. And there are multiple reasons for that. It could be a poor prep, it could be a lot of different things, but there are certain blind areas that we have everywhere in medicine, and this is one of the areas. Those flat polyps are areas that if it's not obvious, sometimes those can be missed.
Correct. And there was a question about sigmoidoscopy. And, you know, a colonoscopy, again, is when we look at the whole colon, but a sigmoidoscopy is when we're looking at a part of the colon called the sigmoid. So it goes maybe a third of the way through. And one of the things that we've learned over the years is that polyps can occur on the right side of the colon, sometimes more so than on the left side of the colon. So a sigmoidoscopy is a way that we would screen for colon cancer as well, but it doesn't look at the right part of the colon. So the exam is not as complete, and you could miss one of those types of polyps as well.
We've gone away from doing it. I think sigmoidoscopy is the concept of doing a sigmoidoscopy is that it could quickly be done in the office without the sedation. I think that's the kind of the historic background to it. And family practitioners did it. So it was more widespread in terms of who was doing it. Now I think it's essentially if you're going to do a sigmoidoscopy, you do a colonoscopy, and the prep and everything, it doesn't, you know, it's essentially the same, and it gives you more, you see the entire colon as opposed to seeing just the left side. That same question, just to follow up on that same question, when do we stop screening? And I think the same thing applies for every cancer we deal with. We stop screening, so we have a screening range that's accepted by the societies. So 50, you start at 50 or 45, and then you end at 70. And that's kind of the range, just in general, for most cancers. The actual age is individual. So I'm not going to tell a 80-year-old not to get a screen if that 80-year-old is going to live the next 10, 15 years. So it's all based on an individual discussion with your doctor and your relative health and what else is going on. But there's the book answer of what the recommendations are for, you know, stopping screening, which is not really, it's really an individual thing. So
it's unrelated to insurance companies?
I do not know that specifically.
Kevin, all of these things are related to insurance companies. The risk and what they'll pay for.
Right.
And for the patient, it's a difficult thing. If the insurance company's not going to pay for it, if there's not an indication, then they're not going to want to come out of their pocket.
But we document, you know, we document in the chart, you know, and hopefully that'll help if, you know, and it's more with, for me, not so much screening, but follow-up studies. And after a while, you could be cancer-free for 5 years, and that magical point that we think beyond that you won't get cancer, but that's actually not true. Your cancer risk, although it decreases after 5 years, it doesn't get to zero. So, and there's certain patients who are higher risk from the beginning that we continue to screen it or continue to follow up on. So it's kind of the same discussion. It's an individual basis and decision based on the overall status of that patient.
So you know, a large number of people have something called diverticulitis, and that's easy to see, or diverticulosis, which is. Could you talk about that and whether or not that might be a relative indication for you to be able to get a colonoscopy?
So it's actually an indication to get one. If somebody has a presentation of diverticulitis, when that's inflammation of diverticula, diverticulosis is when there's little pockets that form, right? And everybody's got them. As we get older, we all kind of develop them as kind of a natural evolution in time. But when these get infected, the indication is to do a colonoscopy to screen, because we're not sure if what may have caused it. Could it be potentially a polyp or a tumor or something that could be actually triggering that event? So a colonoscopy is usually indicated.
So that's a
Yep.
backdoor way to get to screening colonoscopy.
It is another way to get in a screening exam. Yes.
You know, Kevin, what I'd like to approach at this time, when or what would determine your decision to take a patient to surgery?
Mhm.
And, you know, what type of surgery is done, number one, and how, you know, how's the recovery period?
Mm.
You know, okay, we've diagnosed that you have a polyp, we may have taken it out. So is that it, or do you go to surgery? Tell me what happens.
So great question. This is a good segue, just going back to the whole polyp issue. So not all polyps are the same. And there are polyps when Dr. Mazur goes in, if he takes out a polyp and it's what we call piecemeal or just biopsies it, and there's still residual tissue left behind, which sometimes we can't avoid. It depends on what that polyp shows when we look at it under the microscope. If it'll show cells that are proliferated, in addition to the cells that are proliferated,
Proliferating, okay.
cells that are growing,
Growing, thank you.
cells that are multiplying.
Right.
And then there's a degree of what we call differentiation, or how similar those cells look to the normal cells. If those cells don't look very similar, we call it undifferentiated. And that makes us a little bit more concerned that in that polyp, there may be cancer. And especially if we didn't take the whole polyp out. So it's a discussion that we have back and forth. So I'll go back to the gastroenterologist and say, well, do you think we can do a procedure where we get the entire polyp out, if it's feasible? And there's certain interventional procedures, advanced colonoscopic procedures that can be done. And if that can be done, is this somebody that we should now do an operation to remove that part of the colon? So that's kind of the first discussion we have. And it's not a discussion that I have or I make on my own. It's, you know, we talk with the pathologists, the gastroenterologist, everybody's involved to see what the best approach is for this particular patient. Now, a common scenario is it's a sessile polyp. You take a piece of it, it shows an adenomatous polyp with high-grade dysplasia. This is a very common scenario. And
that's an aggressive cancer, is what you're
Well,
saying.
it's
An
not a
aggressive
cancer
polyp.
yet.
Oh, it's still the polyp.
It's
Okay.
still a polyp. It's
Okay.
not a cancer, but it has, and again, I use the word dysplasia, which is similar to differentiation. So we're now concerned that in that polyp, there may be a cancer. And just based on that possibility, we either have to take the whole polyp out to be sure, endoscopically, but if we can't endoscopically remove it, then we have to surgically remove the polyp. Again, this is not a diagnosis of cancer yet. This is just at the level of the polyp. So that's one discussion we have. Now, there are cases where if you do make a diagnosis of cancer, then the next decision is surgery. But even before we get to that, these are scenarios that do occur very frequently in practice. Now, once you do a biopsy and it's a diagnosis of cancer, it depends on where in the colon it is. So the colon, it's the right side, the transverse or middle, left, sigmoid, and then the rectum, which is the lower part. So depending on where in the colon the lesion is, will dictate what part of the colon has to be removed. But even before we talk about surgery, after we make a diagnosis by colonoscopy, we stage your patient. So all cancers, it's a sequence. You make a diagnosis, in this case with colonoscopy and biopsy, you stage or you look at the extent of disease, and based on the extent of the disease, you treat. So with colon cancer, after you make the diagnosis, the next thing is to get a CAT scan of the chest, abdomen, and pelvis to make sure the cancer hasn't gone beyond just the colon itself. The if the cancer has gone beyond the colon, then it's stage 4. Even in select cases of patients with stage 4, we can still cure them with an operation. But for the most part, as long as it's confined to the colon and probably the lymph nodes, the next step is a surgical procedure. That surgical procedure is called a colectomy. If it's on the right side, it's a right colectomy. If it's on the left side, it's a left colectomy. If it's a sigmoid, it's a sigmoid colectomy. And if it's in the rectum, depending on where in the rectum it is, it's either a low anterior resection or an abdominal perineal resection. But you remove that part of the colon based on the location of where the tumor is. After you remove the colon, you'll get a final stage. So there's a clinical stage. So we stage it based on imaging. As long as there's no disease outside of the colon, we proceed with surgery. Surgery tells us the final stage. So we'll see if the lymph nodes are positive or negative. If the lymph nodes are positive, then it becomes stage 3, and those patients are candidates for additional treatment in the form of chemotherapy. So we know that in patients who have lymph node metastasis, just taking the tumor out surgically, a significant portion of those patients will go on to develop recurrent disease. So we know that by adding chemotherapy, we can reduce that risk of those patients getting recurrence.
Excellent, excellent. Yeah, the thing of it is that when you take the colon and you resect part of the colon, how many patients, or is it always the patient is going to have a ostomy, or tell me the reasons why someone would not be reconnected, their bowel would be reconnected, or there are patients, I think sometimes that their bowel may be reconnected later.
Mhm.
Is there, as part of this surgery?
So there are 2 components to that. Anytime you operate on the large intestine, there's always a possibility of having a colostomy. That possibility decreases the more proximal you get into the colon. So proximal means so right-sided lesions, it's less likely compared to left-sided lesions. So
Okay.
as you go further down in the large intestinal tract, the risk of needing a colostomy decreases.
Hold on for a minute, Kevin, because we're talking to a lot of laymen. When you say right side, now just describe your colon, your smaller bowel coming off the stomach, and right side, left side, so they'll understand how their bowel actually comes through to the rectum, from the stomach to the rectum. Can you just take a moment and describe that?
So let's see, how do I do this without a picture? So it's a very, very, very long tube.
Right.
The large intestine is the last part of the digestive tract of that long tube. And the caliber of the large intestine it's the largest, besides the stomach, it's the largest area. Now it comes up the right side of the abdomen, comes across, goes down the left side, and then comes out through the anus. Each part of the colon is designed to do a little bit, well, the colon itself is designed for reabsorption, but each part, or the removal of each part, will affect us a little bit differently. So if you remove the right side, the postoperative issues are a little bit different than if you remove the left side. And it also depends on how much of the intestine you remove. So it's not just the right or the left, it's also how much of the right and how much of the left you're taking out. Now, the decision to put things or reconnect, so after you take things out, it's like plumbing. You move the pipe, you got to put it back together. The decision to put things back together depends on the likelihood of that area healing. there are patients who we know for sure have poor healing capacity where it's dangerous for us to put them back together.
Mhm.
In that patient, we will plan ahead of time or have a very high risk or high chance of doing an ostomy. If patients are healthy and it seems like a good environment to put things back together, then we always do that.
Mhm.
Now, the only time that we can't physically do that is if the cancer is all the way down at the bottom. If it's all the way down at the bottom, then there's nothing to reconnect to. So those patients definitely need to have a colostomy, and that's in patients with very low rectal cancers.
Mhm.
Everybody else besides those patients, theoretically, you can put them back together.
Mhm.
Whether or not we do that is a judgment call, dependent on how likely we think that healing process is going to work.
Alrighty. And things like, just my last question, and I'll get to Dr. Patrick Anderson, who has his hands up. That healing process, what determines that? Is it diabetes? Is it obesity? Is it, how do you make that decision?
Everything. So diabetes, hypertension, heart disease, the nutritional status, obesity. So everything theoretically contributes to it, and we put patients in categories. So we know if you're malnourished, if your albumin is low, if you're on steroids, if you're poorly controlled diabetic, all these things put you in a high risk criteria for poor wound healing.
Mhm.
And then we have to make a judgment: is it safe to do an anastomosis in that situation? Because
Anastomosis.
a connection. Sorry.
Reconnect you.
So, and the problem with connections is that we have to have them heal. When connections don't heal, the intestinal contents leak, and leakage can lead to serious complications. And that we try to avoid. If we know ahead of time that this is a high risk, then we upfront don't do those things.
Okay. Excellent, excellent. Dr. Anderson, please.
Yeah, so from a screening perspective, again, are we just focused on the colon, or are we focused on the gastrointestinal tract throughout? Because then I would like to ask, do the same parameters that requires a colonoscopy, are those the same requirements for screening endoscopy?
No, and part of the reason is because colon cancer is just more common. Gastric cancer is less common, and it's something that we would consider an endoscopy. Usually if people have symptoms like abdominal pain, there may be an anemia on the labs, a family history of esophageal or gastric cancer or difficulty with eating. There are indications for the upper endoscopy, but it's not part of the screening guidelines for patients who have no symptoms for screening.
Yeah.
I have a question for either Patrick and Omar. Are there any sort of dietary things that you might do that might help to decrease the incidence of colon cancer? I know that they talk about certain foods that might increase the risk, or there's certain types of diets that might decrease the risk. Could you talk about the dietary influence on colon cancer?
Yeah. I think that's a very good question, very important as well. The number one thing I think is fiber. I think you need fiber in your diet so that you can have regular bowel movements. That's so important. If you're not having bowel movements, when we make rounds in the ICU every morning, the first question, well, one of the questions that we ask each and every patient, have they have a bowel movement? And that is it, even as far as healing is concerned, and as far as it's not necessary that you have a bowel problem. It could be you could have sepsis or on the ventilator or a pneumonia. It doesn't matter. Did the patient have a bowel movement? Because it's so important. I think it allows our immune system to make sure that it continues to be healthy. It just gets rid of so many toxins and allows our body to get rid of the waste. The other thing is that there are people that like to eat a lot of heavy and red meat, and a lot of people really complain that they have much more constipation depending on what type of foods they eat and how often and the amount that they eat. Those are two things that I can think of off the top of my head. Dr. Ali, or Patrick, can you help us out?
I think
Tobacco.
anecdotally, whenever there is chronic inflammation and we touch on inflammatory bowel disorders, it also is a risk for developing cellular changes which can become malignant. So diets that are rich in foods that are considered anti-inflammatory, such as garlic and turmeric, and those kind of diets are often recommended. And then there are medications where there's some loose data that suggests, and Kevin may also know this, that suggests that certain NSAIDs, certain non-steroidal anti-inflammatory drugs, can help prevent malignant transformation that can occur in polyps.
Yeah.
The other question.
Hold on, Dr. Ali, go ahead, and then
Yeah.
Dr. Sprott.
Tobacco use is another risk factor. Obesity is a risk factor as well. And then we mentioned the hereditary part is about 20%. That's the highest risk factor. But these other pieces obviously are very important, the lifestyle changes.
You know, yeah, one of the major function of the colon is to remove water from the stool. And so, and if you think about it, when you have a bowel movement, the hardest part of the stool is that part that's at the rectum, and the water content sort of goes up, which means that the stool that's been in your GI tract for the longest amount of time will have less water, and that makes it hard and then dry and maybe uncomfortable to pass. But there's a lot of bacteria that are in the lower part of the gut, not so much in the upper part because of the acid that's made by the stomach and all, and where a lot of the digestion and absorption occurs. But any research on the use of probiotics and what may or may not be influenced as it relates to cancer?
So that's an excellent question. And it's one, when we look at the data, unfortunately, we do not have any good, reliable data that shows that probiotics works in prevention of colon cancer or even in use of a lot of other GI related issues. The one place where we do have data in probiotics is in patients who have a special kind of surgery where they've had a colectomy and they've had an ileopouch anal anastomosis. And that's where they take the small intestine and make a rectum or a reservoir from it. And when that happens, there's a condition that is called pouchitis, where it's a chronic inflammatory condition of that pouch or that reservoir. And we know that probiotics can work in helping to treat that or prevent pouchitis. But outside of that, we don't have really a lot of good data, reliable, reproducible data that shows that it works. As a matter of fact, there's even some studies that have come out showing some harm. And part of that is because you're introducing another strain, another bacterial strain into your system. And depending on if somebody's immunosuppressed or whatnot, that can have an effect in a negative way, potentially.
It's a very difficult the question to answer. And I think what we're in the ability to study the microbiome, which is the whole gut content of bacteria, and the analysis has kind of exploded the field. So now before we were doing culture-based techniques to see what bacteria is there, but now we can analyze it by DNA, so we can see exactly what's there. The problem is what's normal, what's abnormal, and that changes over time. If you have a particular diet, that can change the type of bacteria that's in your system. If you take antibiotics, for sure that's going to change the bacteria that's in your system. What your makeup or what a particular type of makeup, how does that contribute to disease states, either inflammatory, autoimmune states, inflammatory states. It becomes very complicated because you have to see what is baseline, and how does any change from baseline affect a potential disease state. One of the things that we look at is, so we do bowel preps all the time. When you do a bowel prep, you change the natural bacterial makeup. And we know that at baseline, you have good bacteria that's there, that's needed to help support the function of the mucosa and the intestine. So it becomes very complicated to answer those questions. Is if you replace it, or if you give additional, is it gonna help? It depends on what was there before and what potential disease states were there, and how does the body or the host interact with the existing bacterial composition that's there. But very, very interesting. And actually it's being studied. We're studying it not so much in terms of colon cancer development, but in terms of wound healing. So we know that when you, the content itself and the makeup can affect wound healing. And that's one of the things that's looked at. One of the contributing factors to breakdown of wounds is what happens with that the bacterial makeup.
You know, Kevin, there's a lot of I'm going to end this, but there's a lot of promotion of probiotics, and my concern has always been that, you know, the bacteria that are in the gut occupy all the space topically that's on the gut. And so it's not necessarily welcoming of newly introduced bacteria that might come through the mouth. And most of the bacteria that might have a chance are invasive in nature and cause disease, like Shigella and Salmonella, or some of those kinds of things. And so you are right that if one takes an antibiotic and the antibiotic kills some of the normal bacteria or the normal flora of the gut, that allows for an opportunity for you to maybe introduce a probiotic or good bacteria that might be helpful. But I as you said, I don't know a good way that you can actually measure a baseline and then measure a change after you start taking something.
And the problem with probiotics is that there are so many different kinds out there. You mean, you go to the grocery store
and varying expense.
They're ridiculously expensive. And, you know, they're also not regulated by the FDA. These are all natural supplements. So you don't know really what's in them, and they're not required to report it.
But they can make all sorts of claims about its benefits.
Right, true. So true. Dr. Court, you've had your hand up for some time and being
Quite a while.
patient, and I love it. Thank you.
I'll let you guys ignore me. That's okay. I have to go back to gastric reflux. For Dr. Ali, what's the role of EGD in terms of treatment of gastric reflux? And also, in patients with gastric reflux, what are the chances of that this may contribute to development of adenocarcinoma of the stomach, for example?
So that's a great question, and the reason is you're right. Well, gastric reflux, 10% of people who have gastric reflux can develop a condition in the lining of the esophagus called Barrett's esophagus. And Barrett's esophagus is the precursor condition to esophageal cancer, okay, esophageal adenocarcinoma. And reflux is one of the most common things that we see. It's one of the most common conditions on the planet. And the risk of development of esophageal cancer from Barrett's is very low. But one of the reasons we may do an endoscopy is to screen for Barrett's esophagus for somebody who has chronic reflux.
Excellent.
You know, it's always interesting because I think there's patients present with a number of complaints and symptoms. We call it gastritis, reflux, etc. But there's patients who are asymptomatic who have significant reflux who don't have any of those symptoms, who you would imagine the same process is going on and the same possibility of cancer development is going on there. So it's always hard, you know, and also on top of that, the association with H. pylori. I don't know if we want to get into that or not. There are a lot of patients who are colonized with H. pylori. It doesn't necessarily mean that it's causing a problem or symptoms, but we treat everybody just based on the fact that it's positive.
But
Let me,
Dr.
let,
Ali,
let, let me do this, Dr. Court, let me do this. Hold your question, Dr. Court. Let me do this. It's halftime, and I'd like to acknowledge everybody. We have some physicians that have come on that we didn't introduce. Let's do our halftime. And we also have a few questions that's come through that I think, and it pertains to GI. Hopefully, Dr. And just to let everyone know, we advertised that we would be talking about orthopedics this webinar. I'm so sorry, but Dr. Lee had 3 emergency surgeries this morning, and he's hopeful that he will be able to join before the webinar is over. At least we can get several of these orthopedic questions answered. Okay, so to understand, and just let me go through my spiel. Our webinar is every second Saturday at 1 o'clock. Please tell others about it, your church members, family, friends, because it takes a village to get the information out there, to let people know that we exist, and this education to us is so important that we deliver it. So that's every second Saturday at 1 o'clock. Just go to OBHealthy and hit the physicians area, and it allow you to enter the webinar and join us. And please type in your medical questions. If you want to look at any of the past medical webinars, you can go to OBHealthy and scroll and just hit our YouTube sign, and all of our webinars are on the YouTube channel. Please view them. Very, very important information. Most important thing, do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you appropriately from a medical standpoint. All righty. I would like to thank OBHealthy for allowing us to bring this webinar to you, and we appreciate all that they do for us. I'd like to see if we can introduce each other, all the doctors once again. Dr. Sprott, please.
Kenny Sprott, I am a pediatrician specialized in critical care pediatrics as well as general pediatrics.
All right, Dr. Atherley.
I'm Trevor Atherley. I'm an interventional cardiologist. I am based predominantly at Newark Beth Israel Medical Center.
All right, Dr. Ali.
Hi, my name is Mazhar Ali. I'm a gastroenterologist in San Diego, California.
All righty, Dr. Clark.
Dr. Kevin Clark, I'm a surgical oncologist. I work at Newark Beth Israel.
All right, Dr. Court.
Dr. James Court, internal medicine, East Orange, New Jersey.
All right, Dr. Patrick Anderson, please. Now you're on mute, Patrick.
Hi, everyone. I'm Dr. Patrick Anderson. I'm a board-certified gynecologic oncologist. I take care of women with cancer, and I work out of Newark Beth Israel Medical Center.
All righty, and welcome, Dr. Aluya.
Thank you so much. Sorry I came in late. I'm having some problem logging in. But my name is Nelson Aluya, medicine and pediatrics trained. Currently Chief Medical Officer of the Newark Community Health Centers, so federal health qualified centers that serves thousands of members of the community in the Essex County area of New Jersey. It's a pleasure to meet you once again.
Thank you, thank you. All righty, so let's just tackle a few, at least 2 questions here that have come through. Well, several others that come through as well. During a colonoscopy, you see the polyps. Can you just clip and get rid of them? I think we covered this, but let's cover it again. Dr. Ali, what about clipping polyps and just getting rid of them?
So when we get rid of the polyps, so yeah, we can do a few different things. We could take a little forceps, like we have little pliers, we could pluck it out, or I have like this little lasso where I can strangle it and pull it out that way. And sometimes we use cautery to burn it off as well. But whenever we take a polyp out, we will send it to pathology for analysis. And that's how we would know if something is benign or precancerous. And based on that pathology, it may also tell us when their next colonoscopy would be recommended.
All right, excellent. The second question is, That was good regarding the probiotics. Is it okay to take on a regular basis?
We don't know.
So, what I tell people all the time is that if a probiotic, first I meet people where they take probiotics and they feel it helps them. And if you feel like it helps you, great. But if you don't notice a difference in symptoms, or if you're taking it for a specific indication where you're not noticing a benefit, it may not work overall.
All righty. Okay. All righty. So I will
You want me
get
to do the
to,
hip dysplasia?
I'm sorry.
There's a question about hip dysplasia, 5-year-old.
Yeah, I know. I was trying to wait till Dr. Lee come in to address those if possible.
That's a pediatric
Oh,
case.
well then, let's go, Dr. Sprott. I'm gonna let you handle that one.
So someone, I guess the aunt of a patient who's a 5-year-old girl who has congenital left hip dysplasia. And we were talking about dysplasia early when we were talking about dysplasia of these cells that turn into cancer cells in the gut. And so dysplasia means that sort of abnormal cells in a group of cells are in an organ. And what happens with the hip is a joint that is called a ball and socket joint. And so the femur, which is the large bone in the thigh, has a little round ball that sort of comes off the edge of it, and it's supposed to fit into a socket. And the hip is a weight-bearing joint, which means that when you stand up, you bear weight. That ball, that's the head of the femur, sort of is supposed to fit into a joint in the hip. But if the individual doesn't walk, and we have a number of children that might have something called cerebral palsy, where they might never walk. What they will never develop is that ball and socket joint, because the socket doesn't develop because they aren't bearing weight. So almost every child that's a newborn, we do an examination of the hip, and Nelson can talk about this too, is to see whether or not you hear a click that might indicate that there's maybe some kind of dislocation. And if they find a dislocation, or those hips are, I'll say, dislocatable, because again, that socket doesn't form very well, it's easy for that joint to become abnormal over time. And so if you don't correct it, and usually what they'll do is they'll brace it or fix it so that the individual can start to bear weight and start to have that form. But if it doesn't form, or if it's not corrected, then it will develop what's called an osteoarthritis, which means that it will become irregular and not normal. And so she's 5 years old, and if indeed she was diagnosed as having that hip dysplasia, it might not have been picked up early. It could have been, but sometimes they're diagnosed late. But certainly if she's already having a limp, that there's an issue with it, then she should see a pediatric orthopedist or a pediatric orthopedic surgeon. Should have been involved with her care when it was first diagnosed. And what I couldn't tell from the question is whether or not it was diagnosed at birth, because almost all of these hip dysplasias, they're born with them. And if it's on one side, the question is, why is it on one side, not the other? But the treatment is usually done by a pediatric orthopedist that either puts them in some kind of a brace or put them in some kind of a spica cast that allows for it to stay in place. And as they walk, hopefully it'll develop a joint that becomes round and smooth and won't be dislocatable. Because if it doesn't, then it becomes easily dislocated.
Interesting, interesting. Dr. Aluya, do you have anything? Have you seen this? Do you have anything to add?
Well, I mean, he basically just explained everything detailed in very elementary form that most people will understand. It usually does happen, and a lot of the times it's picked up in post-delivery at the first examination of a pediatrician, and that's why it's really important that you have a pediatrician who's focused and has a knowledge of those things to feel for that particular click. And if something's wrong, they go on to ask for ultrasound to make better diagnosis. And then the care is taken from there. It's usually non-surgical, they take procedures that's easy and the child does well.
All right, excellent, excellent. There's a question that came in about colonic irrigation, and that the patient has been receiving regular colonic irrigations. And the question also goes on to state that the patient was 90 pounds overweight with Crohn's disease and diabetes, etc. at one time. What are you familiar with anyone that's irrigating of the colon? Can you give us some indication with this, Dr. Ali?
Yeah, colonic irrigation or colonic hydrotherapy is something that I've seen a few patients go through. It's one of these things that we don't recommend. I've seen situations where there's been complications related to this. It sounds like a great idea to kind of wash out the colon, but really what you're doing is you're washing out the microbiome. You're washing out some of the good bacteria. And really, sometimes it can cause some trauma to the lining of the colon as well. So a lot of times people may do this for symptoms of like constipation. I would say, though, we have great medications for this, or fiber as well is very helpful. In Crohn's disease, it's not helpful. If anything, it can increase the risk of opening up more fistulas. It can create more inflammation. In Crohn's disease, we have great medications now that are available to treat the underlying autoimmune issue, and that would be a better alternative.
We're getting a lot of questions coming in. Let me read some of them. I have been diagnosed with Barrett's esophagus and take isopromol OD. What are potential side effects for the long-term use? And I know a lot of patients take these, you know what I mean?
Yeah. So this is actually one of the most common things that we talk about in my office. And it's a great question. And, omeprazole or antacid medications, we call them the class of proton pump inhibitors. They've been around now for decades, and they're very effective in treating reflux. But, unfortunately, over the years, these medications have gotten a little bit of a bad rep. If you look them up online, you may see that there has been risks where they say there's risks associated with infection, hip fractures. There was one with dementia, chronic kidney disease, and it's led to people not using them, which, understandably so. But when you really look at the data, when you really take a deep dive into the literature, what we are noticing in these studies is a lot of these are association-based studies, but not cause and effect type of situations. In an association, with looking at one thing, they happen to find that there's an association with chronic kidney disease. But when you really look at that data is not poor and it's not reproducible. And because we've seen studies where it hasn't shown that with associations. And the other part of this is that for the dementia, there was a concern about dementia, and there was a prospective study looking at PPIs and dementia a few years after the initial claims, and we found that was a negative study. So what I find is that, and what I tell folks is that I think these medications are overall safe, but we always want to make the best attempts to use the lowest effective doses of these medications. So, it's not uncommon for me to meet people and they'll say, oh, I take 4 omeprazoles a day, because they're thinking like it's like a Tums, and they're taking mega doses of these. And we want to move away from the larger doses of these and try to get people on the lowest effective doses. An alternative is what we call an H2 blocker, like Pepcid AC. It's not a proton pump inhibitor. It's a little different, but it works it's very effective as well, and it can be used for the same reasons.
Right, and it's over the counter.
Over the counter.
Yeah.
I'd just like to comment a bit on that, because so often we've seen patients who have mistakenly diagnosed themselves as having reflux esophagitis, reflux, or GERD, it is often called. who in fact merely have the presentation of pain in what we call the epigastrium, that's the pit of the stomach, and sometimes pain in the lower part of the chest and the mid region. I want to caution that because these can be mistaken for, in fact, patients who are truly having what we call ischemic disease or angina pectoris, that is, disease caused by blocked arteries, which can lead to very dangerous consequences, including heart attacks. So there's a great need to diagnose fully these patients who present with and think that they are gastric or coming from the stomach in origin, but may indeed be coming from the heart. We have to note the differences in the presentations, note what is important, notice what risk factors the patients have that may predispose them to one or other of these diseases. And if we are concerned, to order the appropriate tests to rule in or rule out, the differences.
Right, beautiful. Dr. Court, you had your hand up and you're so patient and I do appreciate it. Go ahead.
Okay, we've been discussing colon cancer. How about the stomach? For Dr. Ali, when are they going to be developing some tests or procedures to detect adenocarcinoma of the stomach? Also, is there a role for the amount of hydrochloric acid that the body produces that leads to the development of adenocarcinoma? If not, what are some of the triggers that have been thought of to cause adenocarcinoma of the stomach?
Yeah. So we don't have anything besides an upper endoscopy to diagnose or to evaluate for gastric cancer in terms of an easier test. They sometimes, if we detect like an anemia or like a hemoccult blood, like a stool card where you may see blood in the stool, that could be an indication. And a lot of times in that scenario, not just what I would consider a colonoscopy for somebody who needs one, but also an upper endoscopy. And that's how we can diagnose it. And we don't screen for it like we do for colon cancer. It's we could, and it's, I guess there's a lot of discussions on the pros and cons of it, and it's not as common. And so for any sort of a screening test, kind of a national screening program, right? There's risk benefits, cost benefit ratios, things of that nature. But in any scenario where there's a risk for it or people have symptoms, I have a very low threshold to take a look with an upper endoscopy.
The problem, as you mentioned, it's not a high volume cancer, so to speak. You'd have to identify a well-defined high-risk group, and you have to have a good screening test. And I don't think we have that well planned out.
Same for pancreatic.
Right. There's a question on the chat about H. pylori. So H. pylori is an infection that has been associated with gastric cancer. It's been associated with gastritis and other things also. But we don't have a well-defined group like we do for colon cancer, and the incidence is not as high. So it's very hard to screen for it.
Is the ZE syndrome associated with?
Kevin, you brought up H. pylori. Part of that question is one person in the family has it and positive. Should the rest of the family be tested? And thank you. It says I'm a pediatrician. I'm glad that other physicians are listening to us. That's so great. Can you give us some enlightenment on this, Kevin or Dr. Ali?
I'm going to defer to Dr. Ali and Dr. Spratt.
Yeah, it's a good question, and I think it's very individualized. If anybody wants to request to be tested for it, I test them. Usually if but again, that pre-test probability, if you're having symptoms, then yes, it would be an indication to test for H. pylori. And the way we can test for H. pylori is with a stool test. It's an H. pylori stool antigen test. That's one way we can test. There's a breath test that we could check for it as well. And then third way is by an upper endoscopy with biopsy.
And the reason why it's not as obvious, just to answer the question, the presence of H. pylori, we think is problematic, meaning that every time we see it, we treat it because we think it's causing a problem. But there are clearly patients who it's present, but it's not causing a problem, and it won't cause a problem. So the actual association is not always one-to-one with the actual presence of H. pylori and any symptoms or long-term complications.
Okay, I just want to ask one question. We're saying H. pylori so many times, but we never said what it is. What is H. pylori, so that we don't miss the meaning for
So it's an infection. It's a bacterial infection that can live in the stomach. And sometimes it could live symbiotically in the stomach and not create any problems for people at all.
Right.
And we see high rates of it across the globe. But in some patients, in like 10-15% of patients, you may have symptoms associated with H. pylori where people can develop gastritis, or they could develop a gastric ulcer. And the World Health Organization has also labeled H. pylori as an increased risk for developing stomach or gastric cancers as well. So with people who have H. pylori, that is a risk factor in development of gastric cancer.
Okay, Dr. Sprott is next, and then Dr. Aluya, you got your hands up. Go ahead, Dr. Sprott.
Yeah, so Dr. Court mentioned about the stomach producing acid. So there's cells in the stomach that make hydrochloric acid, which is death to most of the bacteria that you might ingest. So it's very helpful. Not only does it help break down the food, but it kills lots of bacteria. And this H. pylori that's been talked about is a type of bacteria that somehow or another has the ability to survive in this acid environment. We don't know why, but it is able to. And as you know, what was alluded to is it's present in the gut doesn't necessarily mean that there's an infection. And so the fact that it's there and can survive, and it's been associated with these things, we talked about gastritis or ulcers or things like that. When you have those kinds of issues, pain that is associated with it, then they will treat it to try and get rid of it. The question is whether or not it's there and not causing anything. If you sort of go in, you sort of do a test and you see that there's nothing in the gut, the question is if it's not broke, do we need to fix it? And I think that the answer was that it's going to be individualized, that if it's not a problem, you may not need to do it, but yeah, I mean, certainly you can choose to get rid of it. Question is how it got there in the first place and whether or not it'll come back. Which we don't know. But just this issue of reflux, it's mentioned gastrointestinal reflux. There's a band of muscle that separates the stomach from the esophagus. And all children, all babies, anyone that's had a baby knows that babies have reflux. Every time they have a wet burp or they burp up some milk, that's reflux. And we think that over time that reflux that's normal goes away. We find out, but we don't find that those babies that have reflux necessarily have a problem with their esophagus. And why? Because these newborns that are drinking milk, hopefully breast milk, are nursing every 2 to 3 hours, and the milk does what? It offsets the pH of the stomach, and therefore what's being refluxed isn't acidic anymore. It's sort of not so acidic and therefore not likely to burn or to cause damage to that area. And babies are eating every 2 to 3 hours. And so it's not as if that necessarily is going to be a problem. And what I don't know in adults is whether or not some of those individuals that have reflux, they may not have reflux every time that they eat, if they have big meals or things like that. And if it's a big meal, that the contents of that might help offset the acidity that might not result in a problem. If indeed, though, you have someone who's got an empty stomach and is having reflux, they may have the signs of, heartburn, or even actually get all the way up to the throat, and it might cause coughing and things like that. And then it's a problem. Those are the ones that are likely to have problems that need to be looked into. And the treatment isn't so easy. They have these things that they talked about that are trying to decrease the acid amount, but not so much that's going to actually take care of the problem. And the problem of that muscle, that sphincter that goes there, that can be treated surgically, it's not such an easy surgery to do.
Not an easy surgery.
Kevin, you want to talk about that?
Sure. It's
Oh, really?
the operation to try to restore
All right, take care.
or to normalize the pressure in between the abdominal cavity and the thoracic cavity. So what you do is you reinforce the transition zone between where the esophagus goes into the stomach, and you do a wrap. It's called a fundoplication, to try to shore up that particular area to prevent the contents from refluxing back up into the esophagus.
Yeah.
I think we should also answer the follow-up question to this about Barrett's. So there's symptomatic reflux, and then there's the consequences of Barrett's. So I don't know if you want to attack that, Mazer.
Yeah, so, and also I think just to get back to Dr. Court's question as well about reflux, right? The most common cause of reflux in adults is actually that sphincter itself. We call it the lower esophageal sphincter, and that's that muscle that keeps things tight between the esophagus and the stomach. What happens is there's what we call a transient relaxation of that muscle itself. That muscle, for no rhyme or reason, just kind of opens up, and that allows the stomach contents to come into the esophagus and burn that lining. And a lot of times certain foods can trigger it: spicy foods, acidic foods, red sauces. It can occur after meals, but often it occurs at night. And the reason for that is if people eat late, gravity kind of keeps the acid away. It keeps the stomach acid in its place. But when we lay flat, that acid spills over, and then there's more of that relaxation of that sphincter occurring, causing that problem. Now, we talked about Barrett's. Now, Barrett's esophagus occurs in 10% of people who have chronic reflux. People who have suffered from reflux, not every now and then, but kind of chronic reflux, they can develop this. Sometimes people may not even have symptoms, and they can develop Barrett's, or because they have what we call a silent reflux. Okay. But whenever we see Barrett's, so we think about doing an upper endoscopy in people who have chronic reflux, or if they have, they're just not responding to the antacid medications, and we look for Barrett's. And if we do see Barrett's, we confirm that by biopsy. The two things that we usually recommend at that point, it's saying, hey, you got that acid spilling over, it's creating some damage. You're the kind of person that would benefit from being on a antacid medication, a longer term antacid medication, like a PPI, like omeprazole or Prilosec. And we need to take a look at that and survey that every 3 to 5 years. So every 3 to 5 years, and there's a little wiggle room there, we usually would also do an upper endoscopy to just keep an eye on that area.
And Barrett's, you have to understand, you have to look, it's not just Barrett's. It's Barrett's, again, with level of dysplasia, because that'll determine how aggressive the screening or surveillance protocol is, and whether or not you need surgery. So Barrett's with something called high-grade dysplasia is considered to be cancer, and those patients have to undergo an operation.
Yeah, and that dysplasia means how abnormal the cells are.
Right.
Yeah.
And sometimes if we detect that dysplasia early, we can actually endoscopically treat it with thermal therapy.
Okay, we have 3 hands up. Dr. Aluya, you're going to go first, Dr. Sprott, and then Dr. Court. Dr. Aluya, take it off. You're still on mute.
Yeah, since we're on colon cancer and the causative agents and associations that's been taking place, one again is the big issue of the H. pylori, the Helicobacter pylori that was talked about. I think I read something a while ago talking about the evolution of H. pylori and why is it that you have H. pylori in a location where it is. And if you look at that particular area, it's very acidic. And to think that you have a bug that is living there, there must be a reason. And if it evolved, meaning it had evolved with us as human beings or as animals in itself. Now the question is, why is it there? What's it doing? And why this whole fixation on H. pylori and the risk and the adverse outcomes of H. pylori? I think in 2015, it was said, somebody wrote something and said that over 50% of the world population actually carry H. pylori. So if the world 50% is carrying H. pylori, there's a reason why it's there, and it's beneficial. And some people say it causes, we know the disease that it says to cause. However, there are different strains of it. And there are some strains that actually result in disease, but there are strains that don't. Now, the question is, which strain is it? Now, but you find H. pylori more in, and especially in my practice, some of the things I saw way back that I noticed even at Rutgers University, in the New Jersey Medical School, I realized that most of the people who that had GI issues, that had H. pylori, were actually immigrants. And the same study shows that you have more people getting H. pylori in developing countries than in more, developed countries. And there were studies to show that people pick it up at a younger age. As a matter of fact, children pick it up as early as, when they start crawling or something, and that's where it begins to infect them. But it doesn't cause any disease or anything in them. But as time goes on, maybe other strains or other issues come up and they pick up, pathogenic or disease-causing entities that really, result in diseases. So in as much as we focused on it, there's a reason why it's there. If it's not causing anything, something, most likely I think you should leave it alone. There's a reason why it's there for God's sake. But coming down to colon cancer, maybe they've talked about this before. I came in late, and I'm sorry again. The teaching back in the days. I may not be as old in the career as a lot of people, but I've read the old books where they said, God, if you must take me, please don't take me by the rectum. I mean, in colon cancer and colorectal cancer, and that was the teaching, because back in the days it was more of an older, elderly person's disease. But we begin to see where, a cutoff for, screening is decreasing and decreasing. At first it was 50, then 46. As we speak now, it's 45. Now, Dr. Ali, maybe you guys talked about this. What is the future of colon cancer and its evolution? Because it seems to be evolving as we speak right now. And what then would we now say in the future should we begin to screen people with colon cancer, especially in those of African descent? Because that's where the big issue is coming up from. Now, we've talked about some same things here before, where we begin to talk about the anthropological changes in us as a people as we migrated out of Africa, and the food that we eat, and is resulting in the blunting of our GI tract. We haven't, evolved long enough to adapt to the food that we're exposed to that originally was not built for our DNA. And that's a different talk for another day. But these are things that we must begin to think and think ahead of it. Now, the third question is in terms of treatment. As we speak right now, monoclonal antibody is big, and there are a whole lot of reports saying, I think one came up, was it last week, where one of these new MABs, monoclonal antibodies, was used to treat, I think, 15 people with advanced colon cancer, and it treated everybody 100%. What's your thought about that? And should we as a people get into that clinical research?
These are great questions. And
You got to answer them all, Major.
but they're great questions, and I think that these are the questions that we need to ask as we move forward and we think about how we're going to prevent, right? I think that in medicine we focus on how are we going to put out this fire, how are we going to treat this disease, but you bring up a good point here where this is an evolution that we're seeing, and what can we do to address that? And it's going to be, I think it's going to be technology. We have better technology from when I started to now with the way we do endoscopies, with development of Cologuard, right? When I first started, we didn't have that. I think part of it is stigma for screening, it's access for screening, and needing to screen earlier. And these are pieces that we still need to be a part of and educate the community for, lack of knowledge. diet is a very important piece of this. And I think that, you talked about that evolution of things that, we used to eat, and, things change. And now in the world of processed foods and kind of industrialization, our diets are very different, and globalization. But, and I think that plays a big role here. We don't really talk too much about diet, except, we know that there's some studies that show red meat can trigger or be a risk factor for colon cancer, but, processed foods is a whole nother entity here, right? And it's not just colon cancer, though, it's all cancers we're seeing too. So
I think when we say diet, it's not just diet, it's environmental exposure, because diet is one aspect, but it's everything else that you're exposed to. If there's electromagnetic radiation that's around you, that's going to increase it. There's lots of things that's going to increase it. The issue with cancer over time is very interesting and very hard to answer. You only get cancer a certain way. It has to do with the mechanics within the cell. So cancer is only going to develop in a definable amount of ways. The issue is the process that affects it or drives that may change over time. So we think of aging as just a process of getting cancer, and that's because as you age, you have more chances of getting wide mutation. If those mutations happen at a faster rate because of either environmental exposure or there's a particular risk or group that's overrepresented, then you're going to have a shift in the incidence of that cancer. So
the problem with
look
colon
different.
cancer is we're seeing the younger and younger age group. That's what the issue is, really.
Right, and it's hard to tease out exactly why that is. Again, you only get cancer by having DNA mutation, right? You're not going to get cancer any other way. So you have to look at, why is that happening? And it's happening in an early age because the processes that would normally take, decades over time is happening at a much truncated or faster rate, or the particular population is more susceptible to these mutations. That's the only two ways where you're going to get cancer.
Excellent.
So
Yeah, go ahead. Dr. Sprott, yes, go ahead.
So what you touched on, Nelson, in terms of cancer therapy, are some of the newer platforms of cancer therapy are related to immunotherapy, where your immune system is used to attack the cancer. Many people believe that abnormal cells, cancer cells, occur in the body all the time, and that your immune system is able to recognize them and destroy them, specifically a type of white blood cell, and they call them killer T cells that find these abnormal cells and kill them. The question then becomes whether or not somehow or another cancer cells are able to evade the detection of these killer T cells. So what you're seeing now, and there are a number, it's not just cancers, but certain other diseases, but cancer in particular, might be associated with the virus, especially in Patrick's area, certain viral infections, the viruses that cause warts, human papilloma virus associated with certain kinds of cancers. Well, there's certain EBV or Epstein-Barr viruses associated with some nose and throat cancers. So part of what they're developing are these therapeutic platforms where they're able to take these killer T cells, these specialized white cells, and weaponize them against these detection of either abnormal cells that have been infected by a virus like COVID, or certain kinds of cancers. And if these killer cells are weaponized specifically against those cancer cells, they are then infused into a patient that has it, and these killer T cells only kill either infected cells or cancer cells. It's like a silver bullet. And part of the way that they're looking at it, they're doing clinical trials in a number of ways. Certain of the premier cancer centers are using it. It's very expensive. Some of the treatments are $300,000, but there's newer technology that's making it possibly easily available so that physicians can actually administer these killer T cells that have been weaponized in their offices. And it will dramatically impact some of the, I'll say, morbidity associated with radiation, chemotherapy, and sometimes even possibly surgery. So the new technology that's looking at specifically disease cells, I'll call them disease cells, either diseased by viral infections or diseased by cancers and these things. And again, these patients, this 100% cure that you're talking about, with almost no side effects is really something that we're really interested in and looking for the future. But I did want to ask Omar, Patrick, and Dr.
Sir, but before you go on to your question, one of the biggest issue, especially when it comes to healthcare disparity and all that now, we understand that those of African descent have a higher propensity to colon cancer and come out with worse outcomes when it comes to colon cancer. And with these modern therapy that is in available, how many of us are in that space?
So this is
that therapy.
So this no. This is key, really key, because the way that these killer T cells are obtained is by HLA typing. That means that you try to get people, just like they do matches for bone marrow transplants or for kidney transplants or for any transplant, HLA typing. And so what they have difficulty with is having a bank of patients, African Americans in specifically, that have tremendous variability in that typing. Because if you have it, in order to take T cells from me, they have to be compatible. So we need to create a data bank of folks that have HLA typing, so for not just transplants, but specifically for this type of therapy. You hit it on the head. It's the most unknown, diverse group of HLA typing in Africa, in Africans in general, and in African Americans. Very complex and different. But I want to get back to my question. It's just a simple question, but you see this stuff all the time on TV, and we're talking about diets and acid and everything else. What's the story with these alkaline diets? Are these foods that are supposed to be alkaline in nature? Look, I know that they don't do anything to the pH of my blood, but when they talk about these things, what is this all about? Patrick, Maza, tell me, is it a gimmick or what is it?
Listen, I'm not going to profess that I know anything about alkaline diet, alkaline water, any of that. Honestly, I think about it in terms of a global chemical response. If something is not going to change the pH of the serum, I just had a hard time imagining how it would have a systemic effect, except if it alters a chemical reaction that occurs in the stomach. But that I don't know.
But Patrick, you go on alkaline foods and you see a laundry list of foods, cucumber, all this other stuff.
Absolutely.
And do you really think that Dr. Mazer, it changes the pH of the gut when it hits it?
No, because your parietal cells are still going to pump out the acid regardless.
And just remember, our systems is built in so many ways that it creates an equilibrium, right? Most of our physiologic processes function with a negative feedback mechanism. So if things swing one way to the right, it makes its own adjustment. Same thing. If you drink a whole bunch of milk because you swallow an acid, guess what? There's that reaction that occurs because you drank the milk, but also those cells in your stomach is pumping out additional acids or base to make their own adjustments. So in my mind, most of the times, the only reaction that occurs, it's a local reaction that may enhance digestion, that may enhance absorption, but in terms of the global alteration in chemistry, that creates a direct benefit, it's difficult to see it.
Yeah. Dr. Court, you're
No,
waving again.
no, no, no for a change. So that's amazing. I've heard very often that there is an association with amlodipine and lowering the esophageal sphincter, which can lead to gastric reflux. Is that so?
So sometimes we use the amlodipine, the calcium channel blocker, in treating spasms in the esophagus, because sometimes the esophagus can spasm and it can actually relax the smooth muscle along the lining of the esophagus. So technically, if it's relaxing that smooth muscle, it could also cause more of a transient relaxation of that lower esophageal sphincter, leading to more reflux.
Thank you so much.
Yeah. Interesting.
Now,
All right.
I have
Go
a
ahead.
question.
Go ahead.
I've heard a few of people who come to tell me or ask me, like, oh, they do the colonic, cleansing with coffee, and coffee has been used to do that. It just improves the overall well-being of the individual and all that. What's your take on that?
I don't recommend it. I don't have any data that shows that there's some true benefit there. The rectum is, it can absorb things, right? Enemas could be used in the setting of treating like constipation, etc. Coffee enemas, I think a different scenario, where I really don't have any data. And if anything, I do caution about things like colonic hydrotherapies, because I do see, I have seen injury related to it. And you don't want to wash out the microbiome, the good bacteria. So that's a delicate balance that you just don't want to rock that boat.
Nelson, the one thing, and I said it before, the major function of the colon is the removal of water. How much of non-electrolytes and water get absorbed from the colon, I don't know. Certainly, though, I would think that there would be a danger if large quantities of water are put into the colon that get absorbed into the body, could make the patient hyponatremic or decrease the electrolyte concentrations in the blood. And I know that there have been some cases associated with it. So, I think that, I don't like the term, I'm not a GI person, but I don't like the term of GI cleansing. I don't think the GI tract is dirty. I mean, we have food that doesn't get broken down and absorbed, that gets through, but that doesn't make it dirty or mean that it needs to be cleansed. It's just, it does a good job of getting rid of stuff on its own. And so you can dilute it or make it, surround it with water, but, coffee and, these other things. Now, they have been, and I've seen in my career, for people that had extremely bad inflammatory bowel disease, topical treatment with steroids to try and help with the inflammation there. But, these cleansing enemas I'm sure there's a pretty price tag associated with whoever is administering.
Yes, a lot of the time, I've heard people talk, and it's really big among the younger age group now, and they talk about holistic care and all the whole stuff and tie it up with diet and all that. But one of the things I tell a lot of people who come ask me those questions, I'm like, listen, you're 25 or 30 years old. You've had the same GI tract for all these years. You never cleansed it. You never did anything, and you did well. You grew up to who you became, and this is where you are. And then now all of a sudden you think colonic cleansing is the ideal thing to you or for you to re-change your entire structure. But then wait on, it's dangerous because there are a couple of things here which a lot of people tend to forget. All the the exposure to viruses and everything else that we've had all our lives, a lot of time get into our body through our GI tract, period. And the GI tract, it's a huge reservoir for memory T cells because it's lined up with what is called Peyer's patches. And we have the neurohumoral immune system that remembers a whole lot of things that are connected up to our brain that
They
tells
call,
our
they
brain,
call the
"Okay,
GI tract the second brain
it
because
is."
of the
So,
neurological
and
input that's
if you
there.
remember, it's also linked up with the autonomic nervous system, which remembers all of those things so that when one virus or one bug comes in, without you telling it, it tells the brain, hey, this is something here. You got exposed to a virus that looked like this 20 years ago. Bring out this set of immune response against this. Once you wash those things up, that's what you took over 20, 30 years to build. You're going to wash them all off completely, and you're exposed to new dangers that are coming from somewhere else. And people tend to, forget that. Outside of the fact that there are conditions where, and I said this, look, nothing in life is permanent. Nothing. Your heart rate, your blood pressure, even the weather is not permanent. Things change. The only thing that's permanent in life is change. The way we eat, the pattern we sleep, even your GI tract will not be the same. There are times when you have diarrhea, there are times when you have constipation based on a whole lot of things. But going to a point where you have to change your whole intestinal milieu and a couple of other things based on what you heard or what you've seen, then that's a little bit ill-informed. And again, that's why we do what we do here, so that we inform our community and be advocates for them to say, listen, unless you are backed up, or unless there's an obstruction for something, either mechanical or even chemical, that results in a back-up situation, then there's no need for something like this. Unless you develop an immune disease, for instance, what do you call ulcerative colitis, and what's the other one, Crohn's disease, that you develop, which would put you on another level. I think Dr. Sprott, you alluded to it, where you do, topical, what do you call, anti-inflammatory medications, mesalamine and all the other ones. A lot of the times, there's no need for all these things. So again, it's out there, but we need to stand up for our community and do the right thing.
And,
I have
and,
one
and
comment.
Omar, one of the things I think that goes along with some of these things, a lot of these folks that talk about these cleansing things hint that you can lose weight by doing this.
Yeah.
And so, there's the only weight you're going to lose is the water that you put in that's going to come out, and whatever the stool that was going to come out anyway is going to come out. It does
Right.
nothing to help with weight loss.
Weight loss, no.
One last question. Dr. Ali, what do you think of what Caribbean people do? Once a month, they have to take a clean out or a washout. What does it cost? What does it prove? What does it do?
So as you were talking, this is exactly what's going through my brain. I just remember my childhood and
Yes.
drinking Cinepad,
Yes.
running away from somebody giving me Cinepad to drink. And I grew up in this culture, and I could tell you that your bowels will regulate the way they should. The best friend for the colon is fiber. A matter of fact, there's some medications people take to help them to stay regular, like Senna, Senna derivatives. And actually, there's a component, an ingredient in it that actually pigments the colon dark, and it can cause something called melanosis within the colon, which is, we don't think it has any ill effects towards developing cancers or anything else, but it's not healthy for the colon itself. So I usually say, if you need something to go because you're not having a bowel movement, you're having it, if you're straining, or if it's more than just after 2 days, if you're not having a bowel movement, my go-to as a gastroenterologist is Miralax. And I like Miralax because it doesn't metabolize to the kidney or the liver. You drink it, it just brings more molecules into the gut to bring water into the gut, so you can have a more spontaneous bowel movement. But that's a
Dr. Ali,
cultural shift, and that's something that I know is embedded in our culture.
When I was growing up, it used to be castor oil.
Castor oil.
Well, the thing of it is, growing up in the same culture as Dr. Ali, Dr. Court, and Dr. Clark, I remember my grandmother would line up all us grandkids. Usually, it's an anniversary before we start school in September.
Yeah.
But I think, that's an environment where we would eat a lot of fresh fruits that would fall off the tree on the ground. Oftentimes would have parasites in them, right? And I think anecdotally, that's what they were doing, trying to help us, to get rid of some of those parasites. But that doesn't, I believe, translate into how we acquire food and feed ourselves in today's environment.
All righty, we're definitely over time. Dr. Nelson, you have your hand up, and I'm gonna call on you, but this has to be a short one because we're gonna end pretty soon. You'll be the last one. Go ahead, bro.
Yes, so I raised up my hand, and Dr. Anderson, just took it off the question I was going to ask. And
Okay.
it's based on, culture, growing up, grandma, and all the whole thing,
Mhm.
and the food we eat, and eventually with parasites, worms in the GI tract. How often do you see that, Dr. Maza?
Very rarely, but every now and then I could probably count it on my hands where I'd go in and I'm like, what is that little thing moving in there? We don't really detect it though on endoscopy routinely. And a lot of times it's also dependent on your environment, right? Well, I was in the military, I practiced in Hawaii. It was actually quite common. And I would, doing procedures on soldiers coming back from missions in Indonesia, Southeast Asia. That's actually not uncommon where I may find something, but usually we have stool assays that would detect parasite, ovin parasite. Yeah.
Mhm. All righty, excellent. Thank you. Let me just sum up by stating that this is Dr. Ali, you're amazing. And thank you very much for accepting the invitation to come and join our panel of physicians.
For the challenge.
We appreciate you so much, and we are looking forward to just an ongoing relationship that's going to just be amazing. Thank you very much for all of your knowledge. I would also like to say is that we are going to, and I truly apologize for Dr. Lee. It could not be helped. He's in an emergency OR, and we will definitely have him here. His presentation was I shouldn't say was, is awesome, and we cannot negate that. We have to bring that to you. We will announce which month that he will come on. Please, those who came on to have orthopedic questions answered, please come back. He can answer them, and I just want to follow up as far as and proper orthopedic care to all people out there of African descent. And believe me, as we get older, believe me, we all are going to have some orthopedic problems. So we all have questions, and we all need to be educated as to how to take care of ourselves. Thank you to OBHealthy for allowing us to bring you this webinar. I'm so appreciative of them on sticking with us and supporting us. Remember, it's every second Saturday of the month at 1 o'clock. Please tell family, friends, church members. It takes a village to spread the word, because it's all about caring and sharing. Do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can properly take care of you. All right. Note that all of our past webinars are on OBHealthy. Just scroll to the bottom of the page and hit the YouTube sign. All of our past webinars are there. Please view them and subscribe to the channel so we can continue to bring this to you. I think I covered it all. I look forward to each and every one of you coming back next month and being a part of our webinar, educating yourselves as far as health and wellness. And I appreciate each and every one of the physicians that come on and join me. It's not an easy thing, and to recognize, I must recognize that giving up a Saturday afternoon is really, really difficult for a doctor to do. These brothers are committed, and you cannot imagine some of the things that occurred today. And we expected to have more brothers here. Dr. Daniels called and said there was a child that was hit by a car. He had to run to the OR. Dr. Lee's in the OR. So many things are happening out there. So we're giving you a look into our world and what we have to do each and every day, and the commitment we drive forth so that we can bring this webinar to you. So thank you, each and every one of you. And that's it. I'm not going to preach anymore. Until next time, and thank you. I'm going to say peace and be well. Be well.
Dr.
Take
Ali,
care, everyone. All right, bye-bye.
I'll be in San Diego in May.
Oh, there you go.
Let's get together. Let's have a
Okay.
cup of coffee or grab dinner or something.
All right.
All
That'll
right.
be
All right.
Thank you.
Bye-bye.
Thank you.
All right,
Dr.
bye-bye,
Ali.
everyone.
All right. Bye-bye.